This study is it's from a broader program of research which investigates financial toxicity overall and breast cancer. To define it, financial toxicity is a measure of distress or harm that patients experience related to the cost of their treatment. So what we look to do with this study, particularly like as part of the broader program of research, was to investigate how these financial harms correlate with the quality of life that patients have after their breast cancer operations. We found an important relationship between financial toxicity and psychosocial well-being after breast cancer surgery, as well as the satisfaction that patients have with their reconstructed breasts. The two were correlated: the financial harm and a decrease in quality of life associated with both your well-being and your satisfaction with your breast. Patients are expected to make a lot of decisions, and each sort of have a unique set of pros and cons or trade-offs. So right from the beginning, either having a lumpectomy or a mastectomy, and then going down the road of reconstruction, or having adjuvant type therapy, either with chemo and or radiation, and then moving toward reconstruction. There's like a unique sort of set of decisions that people have to make, and I think that's why it's different. That's why breast cancer is different than a lot of other types of cancer.
First of all, the hope of this paper, the primary hope of this paper, is that we begin to normalize cost conversations in breast cancer surgical encounters, and this extends to the plastic surgeons as well as the surgical oncologists and the medical oncologists. I think just normalizing this conversation creates the space for toxicity to be detected. I think that's the first thing. We should then, to the best we can, contextualize our recommendations to sort of reduce the risk of toxicity. For instance, if someone is a particularly high risk for toxicity, then I think sort of making sure that post-operative visits are scheduled with other participating services, either radiation oncology or medical oncology, to reduce number of trips to and from the care center. So consolidating trips makes sense. Another one is using generic medications where possible. And probably the most important thing is if a patient is noted to be high risk, and I think one thing we can do is sort of connect those people to financial navigation or financial counseling services at our institutions, or external ones that are nonprofits, to help these people out either with copay assistance or insurance plan switching. So I think the biggest thing is A, normalizing these conversations, and B, if a patient is at high risk due to a number of risk factors, then I think we should make concrete steps to mitigate that risk.
I think what people have to do with the results of this study is, number one, consider that, consider the financial reserve, or the financial type burden that patients can handle at the outset, and know that when discussing breast cancer management, that financial outcomes are an important part of that.